Thank you. Thank you, Saraswati and Mohit. Uh, it's been a last minute change. So I've assorted certain very important topics over the last year and non-COVID related sepsis. And when you go through the literature, it looks like the research group all over the world are kind of doing research in the same direction, in the sense that there is a theme which is being taken up by quite a few groups and which are being published. And so that's why I'm going to do some kind of a thematic uh, discussion on the literature which were published in sepsis in the last year. So the first theme, as you know, this has been a hot topic for a while. It went way in the wayside, but looks like still people are very much interested in doing research in this. And as you know, there have been many small trials, so it's a very fertile field for meta-analysis. So hydrocortisone, thiamine and ascorbic acid in sepsis and septic shock, quite a few studies published last year. So this one from Journal of Intensive Care, the HAT therapy, the protocol of AMRIC protocol of hydrocortisone, ascorbic acid and thiamine. And they looked at, they searched all the studies, they just selected randomized controlled trials, and they came out with 9 good studies where they could do a quantitative study. And this was the AMRIC protocol which was followed. Vitamin C 1.5 gram every 6 hours for 4 days, so 6 grams. Thiamine 200 every 12 hours, so 400, and hydrocortisone 200 milligram for 7 days. That's been a standard protocol which is being followed. And what most of the meta-analysis and studies have been focused is change in SOFA over 72 hours, because I think intuitively everybody knew, the researchers knew that this is not going to impact on mortality, because it might be the numbers needed to treat with this HAT trial would be thousands and thousands to know whether there is some impact, because it's not going to make a very big impact. So even few percentage decrease in mortality, if we want to show, it has to be very huge trial. On the other hand, if we can show a decrease in SOFA, can that replicate later on in decrease in mortality? So the first primary outcome, and it definitely shows that this combination decreases SOFA score in 72 hours. So delta SOFA is low in 72 hours. And the sub-study in a septic shock patient, the delta SOFA is definitely low in 72 hours. This is both sepsis and septic shock. And in septic shock as well, there is decrease in SOFA score. The second thing which all the researchers wanted to see is the duration of vasopressor. Again, the duration of vasopressor was also decreased. And if we give this cocktail, so the dose of noradrenaline and the other vasopressors are less. And in this study, they looked at procalcitonin clearance. There are only 2 studies which looked at this. Though it is a marker of a bacterial infection, but for some reason it looks like even the HAT protocol decreases procalcitonin. It could be by decreasing endotoxemia or by some other means. The exact mechanism is not clear, but PCT clearance is also enhanced. So these 3 were the good things about the AMRIC protocol. But as was more or less surmised by the researchers, that the hospital mortality and 28-day mortality, there was no difference between the intervention and the control. So in the same line, again in the same year, in critical care medicine, the AMRIC protocol was again meta-analyzed. So you see 2 different group of researchers in different part of the world looking at the different articles and doing meta-analysis. And the good thing is they also came out with 8 articles. So looks like that this is basically meta-analysis is a robust one, because it replicates the same kind of search criteria as the previous one and came down with the same kind of a number of articles, which was robust enough. Again, they looked at delta SOFA in 72 hours, which definitely is useful. They used both the MARIC protocol, and it is definitely less. The duration of vasopressor requirement was significantly reduced, just like the previous meta-analysis. But in this, they also looked at the renal composite outcome and the ICU mortality. There was no difference in ICU mortality like the previous one, and there was no difference in acute kidney injury. So this was an additional thing. So hard outcomes, apart from decrease in vasopressor and decrease in SOFA score, if you decrease the vasopressor, as you know, vasopressor requirement is a part of SOFA. So I'm not surprised that both go simultaneously. And I'm also not surprised that if a protocol have hydrocortisone, there will be a decrease in vasopressor and will be a decrease in SOFA score. So that doesn't surprise me. The outcome of these studies, that if you give hydrocortisone, the vasopressor requirement will come down and the SOFA will come down. And that's why probably clinicians, apart from giving hydrocortisone in shock and patients on vasopressors, are not keen on giving vitamin C and thiamine so much nowadays, because intuitively we think it is the hydrocortisone part of this protocol which is causing the benefit. Again, high dose vitamin C on mortality in patient with sepsis. So the previous two studies were on critically ill patient, not related to sepsis. And again, a meta-analysis just on a subset of patient with sepsis and whether it helps or not. Again, vitamin C, they took some trials which included only vitamin C and also trials which had vitamin C, thiamine, and hydrocortisone. In this, there was a little, the forest plot towards favoring vitamin C, but by and large, it was not significant, the short-term mortality. What was interesting in this meta-analysis is this, the lower right side, non-HAT therapy, that is therapy which included mostly vitamin C. There, they did find there was some improvement, but these were small studies, you know, only 60 patients, 50 patients. So I think here the field is still open as to whether this MARIC protocol is going to help or not. If one takes away the steroid part of it, yes, by giving steroid, the vasopressors requirement will be reduced. Now, Dr. Bellomo and others in Australia and few other researchers were very much interested in mega dose of vitamin C. And that is where they started thinking probably the dose of vitamin C we are giving is not high enough. Though this field is still in the animal study, and the basis of this is it is a good antioxidant if given in a very high dose, and to know whether it is safe and efficacious. So the animal studies were very much astounding in the sense that the heart rate, the temperature, the creatinine, the blood pressure, the norepinephrine dose was decreased to 0, mean arterial pressure increased. One gives the mega dose. I would request everybody to mute their mic. All the delegates need to mute their mic. So, and it was also used in a patient with COVID, with shock, and they gave 60 grams of ascorbic acid over 7 hours. This is Professor Bellomo from Australia who used this. The patient with COVID, this was the only patient, this was the clinical study, not a study, but it was a compassionate use, because on the basis of their animal studies, they could take a consent from the family. He was given 30 grams of vitamin C over 30 minutes, then a maintenance dose of 30 grams over 6.5 hours, and the patient made a very good recovery. So this is just one case study, but again, it tells us the way the field might be going. We might be seeing in future much higher doses of vitamin C and without steroid, whether vitamin C per se at a very high dose is going to be helpful or not. So that is one of the theme on sepsis in the last year. A lot of researchers were still working on this field. The second thing that I picked up was, we keep on talking about capillary leak. Capillary leak is a very common term which is used in daily ward rounds, and we were never able to know whether there is a capillary leak. It was a clinical impression with edemas and all that, pulmonary infiltrate, but there was no objective measurement of capillary leak. And it looks like capillary leak is a kind of a common phenomenon in sepsis, and sepsis mimics. And if we could objectively determine capillary leak and follow that of our therapy, might be a useful tool in intensive care. So there was a proof of concept study, you might say, on diagnosing capillary leak. They took patient with an established subjective capillary leak with edema and all, and patient without, more or less, and healthy people without capillary leak. And they looked at all these scores. They looked at the different serum parameters, and they did a bioelectric impedance method to look at the extracellular water, the fluid balance. They looked at IL-6 and SOFA score, and they had a composite score to look at capillary leak. So basically, instead of going into details of what they did, but this concept of detecting capillary leak, and nowadays these handheld instruments of bioimpedance are gradually coming up, and that those might be helpful along with certain biomarkers to see whether the patient is having a capillary leak, whether it is sepsis or even in non-septic conditions, and to follow that patient whether by therapy this is improving or not. Third is on infection control. As you know, one of the biggest issue that we are facing every day in every ICUs in our country is nosocomial infection with drug-resistant infection. And I have a feeling, yes, hand hygiene and all are there, but water as a source of these bugs is very, very common. And we are very much, we are not at par with the infection control so far as the water hygiene is mentioned, is concerned. So this was a study done in one of the Western countries where they looked at Pseudomonas, which was a resistant Pseudomonas. They did what is a whole genome sequencing. They took environmental samples from the patient's environment, mainly the sink traps and drains, and look at their whole genome sequencing, and saw that the same bug was also retrieved from quite a few patients in the ICU. And they removed this environmental sinks and the water source and made a waterless treatment of the patient. I think what they meant was everything was prepared outside and with no extra water was given to the patient. And after they did this waterless ICU, there was no other infection which was noted. And as you could see, this red ones are the sinks which were removed. The sinks also contained the same Pseudomonas which was retrieved from the patients. So look like unless these sort of exercises are going to be carried out, we'll be losing, I think we lose almost 30–40% of our very sick patients to nosocomial infection. I think there is no shortcut to it. We have to, along with our management and administration, look at the infection control part of it. Reducing antibiotic faced with a very drug-resistant infection is very difficult. So it's a very vicious cycle. I think infection control part is very much missing. Now coming to fungal infection. Now cirrhotics. Now, as you know, there are new risk factors which are being described more and more for fungal infection, of which cirrhosis is coming up in a big way. This was a study which looked at 31,000 cirrhotics, and they studied the fungal infections in these patients, and they found that overall fungal infection rate was around 10%, of which invasive fungal infection 9.5, candidiasis 4, and invasive aspergillosis 2.8%. And pulmonary fungal infections, mostly aspergillosis, urinary tract, bloodstream, these were the sites where the fungal infection was most prevalent. And they found that the highest burden of these fungal infections were there was some geographical distribution, of which India was also a part of it. Non-albicans, candida, and aspergillus were mostly prevalent. And patients with acute and chronic liver failure, as we see in our ICU, most of the patients who get liver failure are acute and chronic. Use of broad spectrum antibiotics, diabetes, and steroids. These were the culprits in cirrhotic patients. So a cirrhotic patient not doing well, looking septic, apart from bacterial infection, we should keep our radar very high as regards the superimposed fungal infections in these patients. Now, another infection control article, chlorhexidine has been used as a standard care by the nursings all over the world, but recently it has been emphasized that there might be aspiration of chlorhexidine, which can cause further damage to the lung and can give rise to VAP. So there has been a tendency to de-adopt chlorhexidine mouthwash and oral cares, and just to do a routine oral care. So this study was done to de-adopt chlorhexidine and switch on to a routine oral care bundle to see whether it decreases mortality in ventilated patient. So it was a cluster trials. Our unit was emphasized on de-adopting chlorhexidine and using bundle, and then it was switched to the other group. So the oral bundle is oral assessment and tooth brushing, mouth moisturization, lip moisturization, and secretion removal every 4 hours. So about 3,000 plus patients were enrolled. And basically what they found, there was not a very significant difference in patients with ventilator associated events, time to extubation, but oral care was better with this oral bundle, and it was not inferior to using chlorhexidine. So it looks like that it is okay to de-adopt chlorhexidine and to go to just a simple oral care bundle. So something which came up last year, which I thought might be of interest. Again, on VAP, probiotics. Probiotics, there is a tendency, there is a change of respiratory microbiome, as you know, as the patients are in ICU on a lot of antibiotics and bombarded with many other therapies. There is a change of respiratory microbiome, just like gut microbiome. Nowadays, there are a lot of work on respiratory microbiome. So if these patients are given probiotics, will that help in decreasing VAP? So a randomized controlled trials, 1,500 plus men and women were randomized in 44 ICUs. 1,300 probiotics, 1,300 placebo. Primary outcome was development of VAP. They did not find much difference of VAP between probiotics and the placebo group. The probiotics were mainly the lactobacillus group. So it looks like at the present moment, just giving probiotics by the gut might not be able to help to decrease incidence of VAP. It might be that it doesn't change the respiratory microbiome. It might change the gut microbiome. Whether it is the assumption was there is aspiration of gut flora, and that might cause change in respiratory microbiome. So I think there might be a different phenomenon going on in the respiratory tract. Now, coming back to septic shock, polymyxin B hemoperfusion, as you know, there has not been much movement in the adjunctive therapy for septic shock. Cytosorb therapy, polymyxin B hemoperfusion has been tried for a while. Now, it has not been of much success. In fact, one of the big study which looked at endotoxin removal by polymyxin failed, but they found that it might be that the endotoxin level that they had as an entry criteria was not correct. In fact, patient with a very high endotoxin also died, and patient with low endotoxin also died. It was in the middle range of endotoxin, which might have been helped by this kind of therapy. But they had a criteria of endotoxin above certain level. So they thought the higher the endotoxin, the better will be this therapy. Now, this was an easier way to look at the SOFA score and see whether it helps or not. This is from Japan. They had 2,000 patients who received this therapy and were matched with a similar patient who did not receive this therapy. And just like that endotoxin study, they also found that patients with very low SOFA or a very high SOFA were not helped with this therapy. Whereas patients in the middle range of SOFA, that is 7 to 12, were helped with polymyxin B therapy. So it looks like that in order to, if we have to give a patient this kind of an expensive adjunctive therapy, might be worthwhile looking at the SOFA score, and very low SOFA or a very high SOFA, those patients might be excluded. A few studies on use of beta blockers and tachycardia control in septic shock. Again, a theme which has been done in last year. Quite a few researchers were interested in this. So this is from All India Institute. They looked at enteral ivabradine for heart rate control in septic shock. Patient with persistent tachycardia had a bad outcome, so they thought that why not try ivabradine, which doesn't cause so much of hypotension. So patients with septic shock and persistent tachycardia more than 95 were randomized to ivabradine group and to standard therapy group. Primary outcome was difference in heart rate, which I'm not surprised was definitely low in the ivabradine group. And what they found was heart rate was lower, vasopressor requirement, blood lactate level, SOFA score, everything was were lower in the ivabradine group as compared to the standard group. The ejection fraction, the stroke volume index, they were all better in the ivabradine group. And as was probably, we knew that the mortality is not going to be different in this kind of a study. But at least this study had shown that ivabradine was not harmful and was definitely improved hemodynamics in patients with persistent tachycardia after resuscitation. Now, esmolol, another study which was published, as you know, a very ultra short acting infusion of esmolol. But this study showed that heart rate reduction using esmolol causes, there is an increased risk of hypotension and decreased cardiac index. So there was a warning in this study. On the other hand, another study for ultra short acting beta blocker, again as esmolol and landiolol. This was a study which looked at use of esmolol and landiolol. And what they found was, this was the research question, whether these two molecules in patient with sepsis after resuscitation having persistent tachycardia. So there were 7 RCTs with pooled size of 600 odd patients. And esmolol and landiolol in septic shock was significantly associated with lower mortality. You know, they had improved hemodynamics, and this study shows a lower mortality. The risk reduction was 18.2%, and number needed to treat was 5.5. So looks like, you know, the ivabradine study and this study looks like there is something that we should look for in patient with persistent tachycardia after resuscitation. I think one thing we need to be careful about, the pulse rate is also dependent upon the type of vasopressors and all which have been used, which might be a little confounding in these sort of studies, but something to keep up on our sleeve, whether to use either we use a very ultra short acting beta blocker or ivabradine, whether that would help my patient or not. Inhaled antibiotic, as we know, even the guidelines are not very clear whether adjunctive inhaled antibiotics for VAP are going to be helpful. Again, a fertile field for meta-analysis. So this was a study which looked at 11 RCTs, 1,200 patients, adjunctive antibiotics. Again, there is no change in mortality. There was some increase in clinical cure and microbiological eradication and increased risk of bronchospasm. So there was no definite hard endpoint change in this kind of studies. Coming to fungus, invasive aspergillosis is more common with influenza than with COVID. Many patients with influenza, it is said almost 10 to 15% of severe influenza who are ventilated, land up in ICU, can have pulmonary aspergillosis. So can a prophylaxis of posaconazole be helpful? So they looked at this prophylaxis of this, and they did not find there was the incident of invasive aspergillosis was not significantly reduced in the posaconazole arm as opposed to the standard care arm. So not a very useful strategy. Now there is a algorithmic approach to diagnose invasive aspergillosis in ICU. As you know, the standard approach is for immunosuppressed patient by URTC criteria, but critically ill patients do not follow this kind of classical picture. There is no halo signs and the imaging is not very classical. So this ASP-ICU algorithm has been proposed, that patient at risk of infection like cirrhotic we mentioned, and some kind of imaging changes. Now they have come out with BM ASP-ICU, which includes biomarkers for aspergillus, and see whether that is going to be helpful or not. So they looked at BM ASP-ICU and compared with the gold standard of pathology proven invasive aspergillosis. And what they found was the BM ICU was much more better than plain ASP-ICU algorithm. So if we use galactomannan, both serum and bronchoalveolar, more of a bronchoalveolar lavage galactomannan and aspergillus PCR, that would increase the specificity and sensitivity of ASP-ICU algorithm. Final few articles, risk factors for invasive candidiasis in critical ill patient. We know there are a host of risk factors, but this latest meta-analysis is emphasizing on these 5 big risk factors. Broad spectrum antibiotics are the biggest risk factor for invasive candidiasis. So no surprise that we do have, though we do not diagnose all the time invasive candidiasis, but many of our patients who deteriorate in spite of treatment with antibiotics probably have candidemia. As broad spectrum antibiotics is a biggest risk factors, so is blood transfusion. Again, this is something which was new to me, blood transfusion as a risk factor for candidiasis. And candida colonization, CB line and TPN is well known. So blood transfusion as a risk factor of candidiasis is also important. As you know, that especially with COVID outbreak, and there is more and more emerging fungal infection in ICU patients. Apart from mucorales, this fusarium and pseudosporium, especially in immunosuppressed patient, and not even classical immunosuppressed, but in ICU patient. So not if a patient is not responding to echinocandin, that doesn't mean the patient doesn't have a fungal infection, because it is very important some kind of a tissue diagnosis, because to diagnose this kind of a difficult fungal infections are very, very difficult. So I would end here. It is just a collage of the different septic articles, mainly the articles on use of ascorbic acid, articles on polymix in hemoperfusion, some infection control articles, and some articles on fungal infections. So I will end up here and hand it over to Dr. Shastri.